A healthcare system. A healthcare system is not just conducted in the vacuum. The World Health Organization has defined long ago what a healthcare system must look like. And they said it has got 6 building blocks. You might simplify it and say it has got 6 pillars. So that when you want to look at your healthcare system, whether it is running well or not, you do it in terms of the pillars. You put yourself in terms of those pillars and see where you are. Now we all know the pillars of any building. If any one of them gets weak, the whole building is going to shake and it will have problems. Now the pillars of healthcare system, if any one of them goes weak, the population will feel it. They won't know, of course, because they don't have that skill or information. They won't know that this is a pillar that's missing. But they will feel it. They will feel that something has gone wrong. Now, the first pillar is leadership and governance. What is the leadership of your healthcare system and how is it governed? The second one, access to essential medicines and other commodities. Early on in this session of government, in this term rather, there was a shortage of syringes and needles in the Eastern Cape because something went wrong with procurement. The population did not know that that is pillar number 2, but they felt it. It was shaking because there are people who can't live without a needle. People who are diabetic, who must inject themselves 3 times a day in order to survive. If you tell them there's no needle, it's a death sentence. So they will definitely feel that there's something wrong with our healthcare system. Then there's a health workforce, which many people will believe is nurses and doctors. Anybody working within the hospital yard constitute part of the health workforce. If you want to see it, just fill the hospital with doctors, surgeons, very senior surgeons and nurses, and have no ladies who sterilize equipment. No operation will be conducted in that hospital. You'll start feeling the importance of the lady who is in the laundry, washing sheets or sterilizing equipment. So the whole health workforce must be looked at. The fourth one, comrades, I put it in red for good reasons, not because of your Congress, but I put it in red. I'll explain to you why. And I'm going to come to it later. Why is it in red? The health system's financing, how your healthcare system is financed. The fifth one, health information system. We are busy implementing it after 8 years of creating it. What we mean, comrades, we are still running a healthcare system where one patient can be treated by 10 different doctors in the same way without any one of the doctors knowing. Not only doctors, institutions. You can go to a private hospital tomorrow. They examine you, they do tests, they give you treatment. You can leave it at home and go to another private hospital and start from the beginning. And on the third day, drop them, go to a public hospital and start from the beginning. You can keep on doing that and putting the medicines back at home. Nobody will know that actually you are repeating because we don't have a health information system that talks to that. We have asked the CSIR to do it. It took them about 8 years, but it's completed. We have just piloted it in the clubbing in the Free State. We are now rolling it. It's going to work in both public and private. It's not solely for the public sector. And we are not the only people in the world who are suffering a lack of a healthcare system, health information system. That's why it's a pillar of healthcare. The last one, health service delivery. This talks to packages to which the population receives health. If I'm a woman and I'm pregnant, what can I expect from the healthcare system? What is there for me? Which is standard, which I may expect, and if it's not there, I can be able to lodge a complaint. Once I deliver a baby, what is due to that baby until the baby reaches our age? Because you need to be nurtured. If tomorrow I contract TB, what do I expect from the healthcare system, both public and private? That's health service delivery. Now, I want to pause a little bit and go to something that is related to what we're dealing with here. What is called the Alma Ata Declaration. Alma Ata is a small town, very small town, in the former Soviet Union. After the dismantlement of the Soviet Union, Alma Ata is in the state of Kazakhstan. On the 6th to the 12th of September 1978, the World Health Organization and UNICEF, United Nations Children's Emergency Fund, they call a joint conference in that small town of Alma Ata to talk about primary health care, because they were worried that except countries such as Cuba, the rest of the world is moving on a curative healthcare system. We are waiting inside the hospital and inviting people to get sick and believe that we have got all the instruments and the power to fix them. That's a curative healthcare system. And that was worrying the UNICEF and World Health Organization. 164 countries attended this conference. There are three things which are on the screen there that emerged from this conference. The first one, they defined health. Even if I may fill this hall with doctors who deal with health and ask them a definition of health, I may likely get as many definitions as there are doctors in the room. Nurses, doctors, or even health workers. Even you, if I ask you today, what do you think is health? I'm going to get as many definitions as the number of people in this conference. And Alma Ata thought it is better to define it. And they said health cannot just be defined as the absence of disease or infirmity. Must be defined in three ways. One, is a state of good physical health, yes. Good physical being, yes, which everybody knows and thinks. But they also said it's also a stage of mental well-being. And lastly, and more important, social well-being. So when you define a health of a nation, you must look at these three things. Are people physically okay? What about mentally? And mental health doesn't mean you are mad. Yes, you can have serious mental problems without being defined as mad. Bereavement is one of those. Losing a job, depression and all that. Now, are those individuals healthy in terms of mental well-being? Social well-being measures many things. It measures education, housing, level of income, etc., etc. And all of them are important to define the health of a nation. Not just because people are not popping pills and what. That's the first thing they did in Alma Ata. The second thing is to declare something that was already declared in 1948, that health is a fundamental human right, and attaining the highest standard is the most important worldwide social goal. That was defined in 1948 during when the World Organization was formed, but also during the Declaration of the Rights of People. They defined health as a fundamental human right. I'm emphasizing it because when you declare a right, you then cannot tell population that they must come and buy that right. But that's what is happening in South Africa today. We have declared healthcare as a right in Section 27, but we are inviting the population and say, those who have got enough money, please come and buy this right. That's what we're doing, and it's wrong. The last, and I'm going to read it verbatim, it's because important. That is Article 2 there. They said the existing gross inequality in the health status of people, particularly between developed and developing countries, as well as within countries, is politically, socially, and economically unacceptable and is therefore of common concern to all countries. That's Alma Ata. Whether you look at inequalities in health from the political point of view, whether socially or even economically, is unacceptable. And countries must be concerned with it and it needs to be changed. Alma Ata ended with a slogan, health for all by the year 2000. Meaning by the year 2000, the healthcare systems must be run in such a way that all human beings experience this highest standard of health. I was a first-year medical student when Alma Ata said, we used to sing this declaration. But because I was an activist, we were not happy with Alma Ata. The fact that they say by the year 2000, because the year 2000 was 22 years away. And we're saying, why do they make us wait for 22 years before people enjoy this higher standard of health? Now the bad news is that 22 years came and went, and the situation became worse in many parts of the world, including in our own country. So the primary health care should be the basis on which healthcare systems are based. That was the essence of Alma Ata. Now, I am going back to that red thing there. Health system financing. When we talk about health system financing, we are not talking about the budget. That one is not complex. It's difficult, but not complex. Ministers of health all over the world, they stand in front of parliaments and read the health budget. That's not what it means. Healthcare financing goes deeper than that, as I'm going to show you later. How do you finance your healthcare system? Why is it red? Because NHI is exactly that. There are many people who give NHI different names. A new healthcare system, which is so expensive that the country cannot afford it. A new healthcare system that needs you to have brand new hospitals, a lot of nurses and a lot of doctors first, and a lot of equipment. You have got to get ready, you must get ready for it and all that. That's exactly what they believe NHI is. It's not, comrades. NHI is simply a healthcare financing system. And it talks to two, and only two things. When you define NHI, the two things must be there. Those who oppose it prefer only the first one. What is it? That every human being must receive good quality health care. Exactly what Alma Ata said. That's number one on NHI. Every human being must receive good quality health care. But number two, which is the one that is being fought in the media and everybody who fights NHI, is that when you receive that healthcare system, you must not suffer financial hardship. You mustn't suffer financially. You mustn't become poor because you got sick. And you may take this as a simple thing because it has never happened to you. The World Health Organization has got figures, numbers of people, and they are counted in billions, not millions, who were never classified poor under the United Nations classifications of poverty, who were never below the poverty datum line. They were living normal life. But somebody got sick at home. Somebody got cancer. Somebody got stroke. And all of a sudden, out of that instance of trying to make this person get well, they now get classified as poor. That's the essence of healthcare information system. Now there, on those building blocks, believe you me, no matter how hard you work, if you don't get number 4 right, forget. All these others, you'll never get them right. And you'll be attacked every day. You'll never get a good work health force. You'll always be having a shortage of doctors or nurses or health workers. You will always have problems with medicines and other commodities and buildings and infrastructure, as I've said. You'll always have problems with health service delivery systems. You won't be able to achieve them if you didn't get number 4 right. And number 4 is NHI. Now, comrades, there are only 3 methods in the world of financing health. If any one of you know the 4th one, please tell me, I'll add it on those slides. But for now, we know only 3 methods of financing health. Yeah, I want you to concentrate very seriously now. The 3 methods of financing health are represented in those graphs. These graphs were made by the World Organization in 2009. It's called National Health Accounts Data Set. They went from country to country. But as you see there on the map, it's Europe, it's mostly countries in the West. They are showing how they finance their health care. The first method is called mandatory prepayment of health. It is blue there on those graphs. It is the blue bars. Mandatory prepayment of health means you are paying for health before the person is sick. That's why they say prepayment. But it's mandatory. Once a country establishes it, it's mandatory for every citizen. That is what is called mandatory prepayment of health. A budget of a country falls within that. Mandatory prepayment is not only the budget. When a minister of health of finance stand up and read and say the health budget this year is this much, he is actually paying for the healthcare system before people are sick. But the manner in which it's done, as I'm going to explain, will define one country from the other. The second is called voluntary prepayment of health. You are paying for health before the person is sick, but you are doing it voluntarily. In South Africa, it has got a very simple name. It is called medical aid. That is the red thing on those graphs. It's called medical aid. I did not put the name medical aid there because I did not develop those graphs. They come from the World Health Organization. And not every country calls this thing medical aids. Countries call this thing different names. Some just call it medical insurance, health insurance, what. We call it medical aid. But the generic international name or global name is voluntary prepayment. That is red. The last is out of pocket. And out of pocket is simple, cash. For everything you get in health, you pay cash from your pocket. In the same, exactly the same way that you do in a supermarket. If you want good health, you must pay for every article. Now the World Health Organization call it out of pocket. Now what are you looking at? What are you seeing there on the screen? As I said, those are mostly rich countries. But when you go to the extreme, that is your extreme right. On the extreme right, there are two countries there. Why they are not standing with the others is because the World Health Organization declared them outliers. Outlier. I think in my language, Pedi, outlier, the nearest definition of it, ke lijela thoko. I think so. I don't know any other way of defining it. Ke lijela thoko. You are doing what other people are not doing. You are alone. Who are the outliers there? This issue of South Africa and US being outliers was defined as far back as 2009. Why are we outliers? Because we are doing what other countries are not doing. Our preferred mode of financing health, as you can see, is red and green. It's what? Medical aid and cash. All other countries are moving to mandatory prepayment. Now, NHI is mandatory prepayment. The World Health Organization called universal health coverage. Not universal health care as people are saying. It's universal health coverage, means everybody must be covered with the money that is available for health within the borders of that country. So we and the US are friends on this. You can call them imperialist, comrade GS, but you are doing exactly what they are doing. In fact, we are worse. As you can see, 60% of our healthcare financing is medical aid or cash. You will notice, anyway, it's important for the communists to know. You can see Cuba is number one there. No, it is. You can see Cuba is there. Towards the end, between Costa Rica and Thailand, is Cuba. It's number one in this healthcare financing for obvious reasons. The other countries follow. But you can see a lot of Scandinavian countries. You can see even the United Kingdom there, the UK, because of what they did in 1948 when they established the National Health Service. It was a healthcare financing system that covered all the Britons. So that's the first thing I want you to notice. But look at this one. Africa, a disaster in the making. This is Africa. The World Health Organization declared it a disaster. Why? Because the most important mode of healthcare financing in Africa is green, meaning what? Cash. It's cash. And this is the continent where people don't have cash, but they are required to pay for their health in cash. The countries where people have got cash, like the Western countries, they are moving towards a different method of financing health. So this is Africa, but you notice something again on that slide. You notice the red, which is cropping up here, is what? South Africa. The second red is Namibia, because Namibians are using South African medical aids. we have actually infected them with our disease. So they are part of us, unfortunately. But comrades, that is worrying. This is not a joke, it's worrying. That in the continent where people generally don't have money, you are saying when you are sick, you must pay cash. I personally experienced this in 2002. I was in Kenya with the state visit with the president. I fell sick during the middle of the night. 2 o'clock, they took me to Nairobi Central Hospital, which is a private hospital. I saw it alive there and kicking. Firstly, they told me, we don't take South African medical aids, even though I've got one of the most expensive medical aids. Now there's a young girl next to my bed with a speed point. With a speed point. Yes, I'm telling you what happened to me in Kenya. I know it's happening in South Africa. But when I saw it in another country, it was very funny. And she said, Minister, the doctor said we must give you an injection. Can you swipe, please? Yes, I took my, debit card. Then I was given an injection. She came back 30 minutes later. Minister, the doctor ordered a drip. We want to put a drip on you. Can you swipe, please? Yes, I swiped for the second time. Third time, they bring another young girl. They said, this is a physiotherapist. Because the problem was the sole of my foot. They said they are going to measure it and put you a pad and all that. Can you swipe, please? I swiped for the third time to get that health care. Meaning, if I did not swipe, no health care. That is the disaster that is in our continent. It happens every day here without you seeing it. So the World Health Organization said we must come with universal health coverage. Those are the countries that started it. There's one myth I want to what you call. There's a one myth I want to demystify. That you need to be rich to come up with universal health coverage. When the UK did it in 1948, how rich were they? It was 3 years after the Second World War. The UK was butchered and battered. They were sick, they were unemployed, and they were poor. And they realized in order to protect the population, we need this system where your treatment must not depend on the strength of your pocket. Many other countries followed later. Even Obama. The thing you call Obamacare, the official name is Affordable Health Care. Barack Obama was not mad. He was aware that the healthcare system in America is going to collapse because it's unreachable now. Many people can no longer afford healthcare in America. I don't know whether you saw what happened last week. A CEO of one of the biggest medical aid schemes was killed. Did you see how people celebrated? Yes, they did. That's very bad. You don't celebrate when somebody is dead. But because they no longer want this privatized insurance system, because they are no longer being treated, they just refuse to pay you, as I'm going to, to treat you, as I'm going to show. I do not want to scare you, but I want you to write it down. If we don't change this system, we are going to arrive there at some stage where the population start celebrating death of other people. It's going to happen. I don't wish it, but it's going to happen. Now, what is the situation in our country in healthcare financing? According to the World Health Organization, they have declared that if a country must run a good healthcare system for its population, it must spend 5% of its GDP on health. I'm not talking about the budget, comrade. Please understand that. It's the GDP. If you spend just 5% of your GDP on health, then you are likely to have a good healthcare system for the population. And there's an unlikelihood that some people, members of the population, will suffer if you spend 5%. Now, where are we in South Africa? We have far exceeded that 5%. We are at 8.5% of the GDP. That's what we are spending on health. How much money is there? It's 570 billion. More than R1 trillion. That's what we are spending on healthcare. So what's wrong? Why are we not getting the results we're supposed to be getting? The people who oppose NHI will give you an answer immediately. Corruption, I'm not going to challenge that. It does happen. Mismanagement, I'm not going to challenge that. Incompetence, I'm not going to challenge that. Negligence, etc. All those, yes, are happening in the public healthcare system. But they are leaving behind the most important one that brought us here where we are. What is it? It is that out of that 570 billion, or 8.5% of the GDP, 570 billion, or 8.5% of the GDP, 51% of it goes to only 14% of the population. That's the gist of our problem. And the remaining 49% goes to 86% of the population. So if you want to see gross inequality in health, you come to South Africa. It is gross in health than in any other sphere. You won't find that in education, but in health it's like that. We are spending 51% of the total health expenditure, which is 8.5% of our GDP, on only 14% of the population. And the 86% of the population must still finish. I know that I might be getting overexcited, but please allow me to show this. Who are these 14% of the population? Many of you here fall within that. You might be communists, but you fall within that, unfortunately. And there's nothing I can do about it. Yes. It's teachers, because they are on medical aids. It's nurses. It's managers, including DGs, DDGs, chief directors. But, it's police. It's the army. It's the judiciary. It's all of us in the executive, starting with the president and all that. We are all part of that 14%. And many of you sitting here, you're part of that 14%. Where between you and your families, we're spending 51% of the total health spent on us and our families, and we are leaving the masses. Now they tell me all the time when there are attacks that this is private money. Why do you worry about medical aid money? In fact, there are people who came and said, look, I pay tax. Take my tax and go and help the poor. Why do you trouble me? Because this is private money. I want to show you it's not private. Every year, the state subsidizes private health care for 70 billion rand. Not million, 70. Why? Because all those people I'm showing there, it was just my way of showing people working for the state. All the people I'm showing there have got a medical aid subsidy. Any one of you who has got a medical aid and working for the state, you are being subsidized. And when we calculate that total money of the subsidy, it's 70 billion. The poor are not having any access to that money. But then there are tax rebates. What are tax rebates? At the end of the year, any person who's on a medical aid, whether you are working for the state or not, it doesn't matter who your employer is. If you have got a medical aid, SARS will give you tax rebates or credits at the end of the year. And those tax credits, they total 30 billion. So when you add 70 billion rand, leave the fiscus through Treasury and SARS to go and subsidize people who are well off. 2 months ago, the president confronted me. He said, Minister, I'm the highest paid public servant in the country. Why am I being subsidized? And I said, Mr. President, unfortunately, you are not the highest paid. Let's start there. You're not. There are people under you who earn more. Yeah. Yes, that's true. Some of these CEOs of medical aid companies, they earn up to 9 million rand per annum. And some of them work for the state. So I said, President, let's forget about you being the highest earner. That's what people think. It's not like that. But let's come to this issue of subsidy. That's where the issue is. Why are we being subsidized? Why are members of parliament, the army, police getting so much subsidy which the masses can't get? This is the problem that we're faced with. Now, what are we doing with this money? Let's look at BRICS. I have excluded the new BRICS members. I've gone to the original BRICS members who were still 5. The middle row, the third row from the bottom, from the top, as you can see it, the highest spender is Brazil. It is spending 9.8 8-9% of its GDP on health. That's number one, Brazil. Number two is South Africa. Our 8.5% put us at number two. Number three is the Russian Federation. We've even overtaken them. Number four is China. We've even overtaken the second biggest economy in the world in terms of healthcare expenditure. India is number last. They've not even reached the recommendation of 5%. India has not even reached there. We have reached it more than 2 times. But what is the issue here? Let's go to health outcomes. What are the health outcomes on health? When we say outcomes, what do we mean? Let's start with life expectancy. As you can see, South Africa is red. Our life expectancy is lower than all those countries, despite the fact that we are number 2 in expenditure. You can go to infant mortality. You can go to maternal mortality. You can go to under 5 mortality. You can go to HIV and AIDS. You can go to prevalence of TB. We are red. The only time where we show with all these BRICS countries our being red, where we are all failing, is in that middle row, as you saw, is what? Is communicable diseases. Diabetes, high blood pressure, cancer. It hits all countries the same all over the world. They are all red. But when it comes to all these other diseases, South Africa is red. Brazil is not red on any of the things except on non-communicable diseases, because it's spending a lot of money, but they are seeing results for it. We don't see the results. We just pour money in, but there are no results, as you can see with that. Now, I'm going to try and skip quite a number of things. What happened to us? Where is all this money go to? What went wrong? If you look at that graph, it shows the private healthcare system in the country. It's only private, there's no public there. As you know, we've got 3 big private healthcare groups: Life Health, Mediclinic, and Netcare. But we also have independent. Independent were small hospitals or clinics. Some of these were just day clinics. They were very affordable. In 1996, they were very prevalent. 50% of the total beds in private healthcare were owned by them, as you can see on the extreme there, 1996. They were having 50% of the beds. In 1998, I don't know why those years appear like that on the screen, but it's 1996, 1998, 2000, 2002, etc. In 1998, something called market concentration happened. You know it very well. When you start mergers and acquisitions, absorbing the smaller ones and making big monopolies and all that, that's market concentration. It took 10 years. At the end of it, you can see the results. The independents were wiped out. They were left with 10% of the beds. Netcare got stolen. Mediclinic also got stolen. But Life Health, more than Mediclinic, as you can see, they now have 90% of the beds. What are the results? They call the shots. They call the prices. They are the ones who are making the prices. Don't think medical aid and specialists are making prices. They are made by private hospitals. And they call any price they want because they now have monopolies. You can look at the price of private health care now. Starting from 1990, it was affordable moving according to inflation. It changed in 1998. That graph there, I mean that arrow, that is heading for the sky. That's the pricing in private health care because of market concentration. Now, this is where the war is. That's why the people who are fighting NHI are not even health workers. Mostly they are business people, if you checked. Yes. The fight that was staged by Busa is because they are in business. Why? Look at that graph. Red is the cost of debt. How much money do you borrow to build a private hospital? And blue there, or purple, is the return on investment or profit. In any business, you start with capital, you owe, You work, you break even, you start making profits. As you can see, the profits here started in 1998. These are not profits, they are super profits. If you think I'm lying, go to compare. There is no place to make a profit in South Africa than in the private healthcare system. Not in the mines, not in energy. No, it's like that. You go to a private hospital. If you have got money, you invest in a mine, you'll get your income after 7 years. Your profit after 7 years. In healthcare, you get it immediately. Yes, and somebody asked me, why do sick people pay so much money? I said, no, because they are scared to die. Comrades, let me tell you here, I'm a doctor. Yes, they are, I'm a doctor. If I go to a colleague who examines me and say you are growing a tumor in your head and we need to remove it and we want 250,000 rand, on what basis am I going to argue with him? I can't see what is inside my head. It's not possible. It's not like a pair of shoes where I can say, oh, this one is mad. Let me go to the next shop. I'm going to agree. You're going to pay. Whatever they want, you'll pay. If you are unable to pay, word goes out in the newspapers, they put you there and they start cheating the nation. That this poor person is sick. For them to get, okay, we want 250,000 and he doesn't have it. Can you pay? And people start feeling guilty, they pay. That is extortion. I don't know, yeah, we're making, yes, it's extortion against the nation. We're making noise against extortion in the construction industry. This is sophisticated extortion. Because where is that money going to? It's not for this person who has got a tumor. It's like, I don't know, I don't want to speak ill of Christianity. I'm still a Christian, by the way. But there are churches these days where poor people donate money, believing they are giving it to God. When they are giving it to Mfundis, yes. So you will believe you are giving this money to this sick person. You're not. They are extorting you. Because the public is not supposed to be paying for health care of individuals in the population. It's not. So, but the reason is that. Now, GPs, people who own surgeries in townships and rural villages, they hate NHI. But I've been meeting them in the last few weeks. They believe NHI is going to make them poor. I show them that they are already poor. This is 2010. No, they are poor, I'm not joking. This is 2010. The amount of money collected by all people who have got medical aids was 84.7 billion. Yes, as you can see, the biggest price went to private hospital. They got 30 billion out of that, followed by specialists, then pharmaceutical companies, then, that's written as medicine there. GPs only got 6.7 billion. All of them. What's wrong with that? Look at the bottom. People who are called non-health, they got 6 billion. People who are called non-health, they never touch a patient. They push paper. They are brokers. They are everything that is to do with the administration of health, except that they don't touch a patient. But they earn more money than doctors in our township and villages. That was 2010. Fast forward now, 2022, not now, 2022, 2 years back. You can see the GPs just moved from 6.2 to 11. The non-health at the bottom is right, 18.9 billion. So 18.9 billion in health care goes to people who have got nothing to do with health. They earn more than doctors. Now, what is worrying? The GPs were earning 6.2 billion in 2010, and it was 7.31% of the health expenditure. Now it has gone to 5.25. What does it mean? GPs are doing primary health care. It means our primary health care is reversing. And what does it mean? For communists to understand it, it means we are actually moving in the opposite direction from where Cuba is going. Because Cuba is using primary health care. We are using a creative health care. In other words, the simplest way to explain it, we are moving away from a system like what is in Cuba, faster to the system that is in America. That's what that 5.25% shows. And that's why I'm saying we are in trouble. Now, I want you to absorb that. Those graphs there, the blue is black people. The gray is white people. I have got to define people by color, unfortunately. In 1960, the first set of graphs shows private sector. It's showing the number of black people who were using the private sector. As you can see, it is that small thing, that small bar there, which is just above zero. It's not even 5%. And the huge one, more than 80%, is white people who are in private health care. In public health care, it reverses. It reverses. In public health care, more than 90% are African. And the whites are only that small percentage, about 20. That was 1960. Fast forward 2015, nothing has changed. The system is still racialized, yes. And what does it mean in real today's terms? 10% of the African population have got medical aid now, but 72% of the white population have got medical aid. That's the system we're having now. I want to repeat this. Only 10%, this system they say we want to destroy, helps only 10% of the African people. But in the white population is 72%. Why do you expect them not to defend it? Why do you? Why is it that it's mostly white people who defend this system and fight and all that? Even in the GNU, of course. You saw how we were attacked, yes. No, but you are taking something from them. You're taking something from them. That's a fact. And if you take something from somebody who's going to fight, because freedom is not free. But the bottom line now, the surprising thing is this. The first person who showed that system is Dr. Henry Clarkman in 1944, who was asked to do a commission because there were poor whites. How do you say poor whites? He came with this type of situation and said, no, the system is not only financially discriminatory, it's also a racial system. Because blacks are on this side, whites are on that side. That was back in 1944. And what was the recommendation of the Clarkman Commission? I've got the report, you can come and fetch it. It was NHI. And why was nothing heard about it? Because 4 years later, National Party came into power. And National Party and NHI could not have been bedfellows. So it was destroyed and we never heard about it. And there are people who believe NHI is only starting now. Now, this is not me, it's from the World Bank. That's the World Bank report. They are comparing the amount of money spent in 64 countries around the world as a percentage of GDP, the one I showed you later. As you can see, the broken line at the bottom is the average for European countries. I told you they are at 9.8%. Mostly European countries, they are spending 9% of their GDP on health, just like Brazil. So we are not far from them at 8.5, but that's the average for Europe. That's why South Africa has got that vertical red line you can see. It's reaching there. At the top of Mount Everest there is the US. They are spending already 22% of their GDP on health. And what are the results? 43% of all the money that is spent on health globally is spent in the US. All the other countries, all of them, the whole of Europe, the whole of Asia, the whole of South America, the whole of Africa, you add them together, they spend the remaining 57%. 43% is spent by the US alone. And that's what Obama was trying to stop because it is moving very fast. In 2012, it was only 12%. Sorry, not 12, 18. And the fact that it has moved so fast within a short space of time is a red flag for the US. But unfortunately, that's the system we are following. Dr. Margaret Chan, who was the Director General of the World Organization before Tedros, she asked me a question I can't answer. I was quite used to her. When we were in Geneva during the World Assembly, he said, Minister, in South Africa, your healthcare system is British. And she's right. We are running a British system, by the way, if you didn't know. The curriculum is British. That's why a nurse can leave South Africa today tomorrow start work, no orientation. She just, yeah, it's the same curriculum. Many young doctors, when they leave here, they go to England, they just work. We are using the curriculum. Well, after all, they were our colonizers. So she says, you are using the British system. Fair. Whether that's good or not is immaterial, but fair. She then said, but when it comes to healthcare financing, you suddenly become American. And she said, tell me, at what stage in your country did you take this off-ramp to America? You were on a British highway, but you off-ramp to America. And she said, Minister, America has bequeathed the West in healthcare to the world. And she mentioned two things. That healthcare financing where I showed you that we in America are outliers. But secondly, this present litigation, I'm sure you saw it, where lawyers litigate and even steal from disabled children. That's an American system, where you sue the hospital system until it's down on its knees. Now in South Africa, because of that, to be a gynecologist in private practice, you must buy insurance for 1.3 million rand first. It was not like that before. You just open your practice. Today, just to open a practice as a gynecologist, you must put 1.3 million on the table. How many people will do that? How many people will be able to do that? That's an American system, so that's what she was asking me. Now I want to show you something interesting there. There's America there at the end, which is spending 22% of GDP on health. Then there's another country. The fifth country after America is Lesotho, our neighbor here. It is number 5 in healthcare expenditure. In the mold of what Americans are doing. What will have happened in Lesotho? For Lesotho to suddenly wake up being the biggest spender in health. And you know very well that we are treating their patients. What happened is that Netcare went to Lesotho. Yes, they went to Lesotho. The biggest hospital in Lesotho in Maseru was Queen Elizabeth Hospital. That was their central hospital. We have got 10. We have got King Edward VIII. We have got Steve Biko. We have got Groteskir, Tigerberg. We have got Chris Hani, Baragwanath, and all that. There are 10. But in Lesotho, it was only 1. And in the center of Maseru, Netcare then goes and said, look, this hospital is dilapidated. There's no equipment, man. How do you call yourself a sovereign state? We will build you a brand new modern hospital and equip it. And of course, Basotho agreed. Netcare went to Lesotho. They built that hospital. Of course, it's state of the art. And they equipped it. And they even duped them and said, why do you name your hospital Queen Elizabeth? That's a colonial name. Don't you have your own queens, man? And of course, Basotho agreed. They named it Queen Mamohatlo. Why am I telling you this story? At some stage, Lesotho was spending more than half of their whole healthcare budget on Queen Mamohatlo. At the moment, Basotho cannot afford Queen Mamohatlo. The irony, they were affording Queen Elizabeth. Now they can't afford Queen Mamohatlo. That's the irony. No, but that's what happened. Then they came to me when Chief Justice Ngobo was doing market inquiry. Dr. Mnyamani, who was the minister then, he's a surgeon, he said, can you allow me to go to Ngobo to show him what Netcare did to Lesotho? Of course, Judge Ngobo refused. He said, that's extraterritorial. The commission is conducting, it's a South African commission. Lesotho went to the World Organization, even to the World Bank, and said, please relieve us from the clutches of Netcare. Of course, they were not successful. So they terminated that contract unilaterally. In January, it's going to court. I'm eagerly waiting to see what will happen in court. Whether the court will allow a small mountain kingdom to be destroyed by that. Now, I'm going to leave this. It just shows the prices. If you look at this report, it shows prices in healthcare, in investigation. That's what is called an angiogram. You can see number 1 is United States, South Africa is there. But on most of them, this is CT scan abdomen. Number 1 in terms of prices, US, South Africa is number 2. We're more expensive than all those countries. Yes, all those rich countries. This is CT scan, pelvis, same thing. This is magnetic resonance imaging, a very powerful instrument that can see a tumor in your brain the size of a head of a pin. It can pick it up. So it's very essential. But who is selling more? United States, South Africa. I can go on. Well, there are places where South Africa is a little bit better, like on this one, and on hospital daycare and all that. But mostly, we are next to the US, and that's what Margaret Chan was asking me about. How did you leave the British trade? Now, I want to show you this graph, because we had NHI in South Africa, but we never called it that. Is there any indication that if you treat people, regardless of their socio-economic conditions, then you get results? That graph there is a graph of maternal mortality. The number of women per 100,000 who die in pregnancy and childbirth, that's maternal mortality. It's a big indicator of development in your country, whether you are developing. As you can see, by 2011, 2010, we're on top of the mountain because of the HIV/AIDS pandemic. We put together that big, world biggest HIV counseling and testing, which you remember. There was an argument in the Department of Health that people who have got medical aid must pay. And I said, no. The moment you bring money in a healthcare system, in the way you want to bring it, you'll never win. I don't care whether you are a billionaire or not. If you are HIV positive, we put you on treatment. And that's what we did, we're still doing even now. We've got 5.5 million people, it's the world biggest. We're not proud of that, but that is true. What has it done to maternal mortality? It came tumbling down until 2019. It went up again, that's COVID. After COVID, it's coming down again. But there it shows that you can actually achieve. If you put financial consideration aside and say, I'm going to treat people, a billionaire, Comrade Blade in Demander's kitchen girl or garden boy and all that, you treat them the same, you are going to get that result. Now, the present system, you see that Mfundisi, he comes from Tebecha. He has got cancer. He has been paying Discovery for 3 decades, 30 years. He was a member of Discovery. He has got cancer. The doctor prescribed a treatment that is costing 1.4 million rand. Discovery is refusing to pay. They are going to tell the congregation, Fundisi is in trouble, please pay. When his money was going to Discovery. That's what they are going to do. They do that all the time. Poor men. You know? There I'm just showing what medical aids are doing. That second patient, and it's not something I'm guessing, that patient gave me the invoice when I was addressing them in a village on NHI. That patient, the second patient, was charged 19,000 rand by the doctor. The medical aid agrees to only pay 5,000. And they say the 13,000 he must see to the finish. That is the out of pocket that we're talking about. Now I want to show you the last slide. They are saying we are not improving the healthcare system. We must put up buildings first before we start NHI. Comrades, I'm informing you. If we did that in health, in education, we'll have been trouble. Do you remember 1994? In Eastern Cape, El Limpopo children were under trees. There were no toilets. There were no laboratories. We had nothing. But we said one education system. If somebody argued that, no, you can't, under Bantu education, you can't mix them with white education or Indian or colored education. Improve them first. We'll still be improving them up to today. There will not have been any change. Because you know some schools still don't have latrines and all that. So we are being told, improve the hospitals first before you start NHI. If you do that, you'll never have NHI. But if you successfully do that, you don't need NHI. What do you need it for? Because you'll have been able to improve the healthcare system. The aim of NHI is to improve the healthcare system. That's what every country did. Now I'm showing you the story of Lisiki. In Lisiki, there was no clinic. They've hired a building from an insurance company. I think it's Momentum Life or so, or Metropolitan, I'm not sure. The MEC then unfortunately clashed with that company. Instead of realizing that he has got a back against the wall, he did a fork and told them, no, he's not going to agree to their rental. They kicked him out, which means if they kick him out, there's no clinic. But people want a clinic there, so this is what was put in as a clinic. The tents. You can see there are women there. This happened in Lisukisiki. We didn't just create it. Mail and Guardian goes to Lisukisiki. They photograph this thing, and at the bottom they write NHI clinic. And yes, you can go and get that copy of Mail and Guardian, NHI clinic. When the states say NHI, this is what they are going to give you. They are still preaching that even today, that this government of yours, when they say NHI, prepare yourself for this. We went to Lisukisiki. This is what we put up. You have never seen it, not in any TV, despite the fact that the president went there officially to open this thing with Zweli Mkhize. It was never shown on any TV or in any paper, because in the minds of people, you must remain with these tents. That's why when one thing happens in Helen Joseph Hospital, it's all over. In Bara, it's all over. Anything that happens in a public hospital is all over. Even at the moment, we are busy renovating 150 hospitals now. And that counts for nothing. I can show you. All the hospitals are renovating, even the new ones we are building. I think there are about 27 new hospitals that we are building, that are totally new or a replacement of those who have aged. We are busy doing that. But in the minds of people who want to destroy NHI, they want the tents. Now, that is still Lisukisiki. Yes, that is Lisukisiki inside. It sees 500 people. And at the same time, we open many others. Can South Africa afford NHI, as they are asking us? This is my last slide. Can we afford it? I've already showed you that we are spending 570 billion. That's half a trillion. There are not many countries that are spending that. If we can just correct the skewed way in which we are spending it. Now they say we must cost NHI. Private health care started in 1967. Nobody costed it. Why should we cost NHI? And is it possible to cost it? How can you cost a lifelong process? In 1994, if they said you must cost democracy, where were you going to start? If they ask you and say you are refusing, yes. Now, they say we must cost it. Comrades, this is what we are going to do. We are going to cost the part we are going to implement. Where are we starting with NHI? Number one, the state has taken a decision that we must start grade R. All 5-year-olds must go to school. Let me tell you, because we have done it in the pilots, which they say have failed. There are many kids who go to school who can't hear very well. And we think they are dull. And mostly they are black. Many kids who can't see very well, and we think they are dull. Many kids who can't speak very well because of oral hygiene problems. There are many. There's an optometrist who asked me, he said, an ophthalmologist said, every year I see children of people with medical aid coming here for eye tests before they go to school. When are the poor ones coming? They are going to school to learn the same thing, but this one cannot see. So we are going to make a rule. Every child, regardless of which home they come from, must have an eye test, hearing, oral hygiene. That is going to be our first. We will cost it and show the nation that our first step of NHI is this, all kids. Our next step, pregnant women. We will draw a program where every woman who's pregnant know their package, that they can go and see a GP 4 times during the pregnancy, and a specialist 2 times, and a CT scan 2 times. That is very much affordable. We can afford it. And I can go on and on and on. Those are the things you'll cost. You can't cost the whole NHI. The story that is going around from Momentum Live, that NHI will cost 1.3 trillion, if you remember that. It's all over. And I said, that's mathematical hooliganism. They thought I'm mad. I am still saying so, because Momentum Live came to meet me and said, I've insulted them. I said, no, but why did you do this? He said, no, it's not us, it's the media. What we're doing different projections. And our projection was, if all South Africans use private health care, it will cost 1.3 trillion. You know that not all South Africans will use private healthcare. If we do that, what do I do with all these big hospitals? What do I do with Barak, Groteskir, Tigerberg, Steve Biko? Am I going to close them and say you are all going private? For what reason must you all go private? And when we say you don't go private, does it mean we are giving you poor quality? No. Comrade Chair, I remember I said last, but you know me. Last, yes. Last. We, by being insulted about long queues, poor quality, mismanagement, comrades, money follows people. If you take money and put it in private healthcare like I've shown you, all the good people will go there. I'm not destroying anybody's name. If I'm lying, go to prove it. Go to Park Lane Clinic. It's here next to Vets. Park Lane Clinic has got 56 gynecologists working there. You don't have to get inside and ask. They put it on the board. They put their names there. There are 56 gynecologists there. What is the significance of that? It's more than the total number of gynecologists in Mpumalanga, Limpopo, and Northwest added together. Yes. We don't have 56 gynecologists in Mpumalanga plus Limpopo plus Northwest. We don't have. They are in one private clinic. And the rest, but how many pregnant women are we treating in the public health care sector? 1,060,000. Because there are 1.2 million people that fall pregnant every year. The private sector, with all that money, 51% of the total healthcare expenditure, they are seeing only 140,000 women. The rest, 1,060,000. They come to the public sector to come and queue there and find no gynecologist. Make your own decision whether we must leave that situation like that. Thank you very much.